We are live. So we are
Good
live.
evening, everyone. At the outset, I would like to welcome you all for the online All India PG teaching program. My dear postgraduates, I must say that it's one of the robust postgraduate program being conducted under the banner of All India Ophthalmic Society by ARC. And under the able leadership of our chairman, Dr. Prashant Bhawankule, I would like to once again welcome you all. So this program, that is the PG with a difference, was designed so that it will help you all not only for the theoretical but also to face the practical situations as well. So as you all are aware, we have divided this into 4 different parts. One is the 1 week we do with the long cases. The second week of the month we do is with the 2 short cases and discussions. The third week we do is with the journal clubs. And the fourth we do is with the chart reading, especially now what we have today is about the OCT and its algorithms. So for this, we have excellent speaker here today for you all, Dr. Rahul Mayer, Senior Consultant, Vitreoretina Services from Dr. Shroff Charity Eye Hospital from Delhi. So he'll be discussing about the OCT, the macula, and its algorithms, and which is most importantly, the practical situations which he'll be explaining it to you all so that it will be helpful for you to face your exams as well. So we have wonderful galaxy. You have wonderful discussants here with us today is Dr. Moona Bhende, madam. She is the Senior Consultant, Vitreoretina Services from Shankar Nethralaya, Chennai. Welcome to this program, madam. And along with her, we have 2 excellent other discussants, Dr. Devendra Venkatramani, Consultant, Lakshmi Eye Hospital from Mumbai. Welcome, Dr. Devendra. And then Dr. Pratyusha Gane. She is the Associate Professor, All India Institute of Medical Sciences, Mangalgiri. Welcome, Dr. Pratyusha.
Thank you so much.
So, my dear postgraduates, I'm sure that you will visit this site because this is being recorded and put up in the ARC YouTube channel. And I'm sure that you will visit this again before going to your exams. Take my words. And it's going to be one of the fantastic program which we are going to have on macula under the banner of ARC. So me, along with my chairman and all my ARC members, once again, welcome you all for this August gathering. So I would request Dr. Rahul Mayer, sir, to please start his presentation, which will be around 30 minutes. And then it'll be ably guided by the discussions from Dr. Moona, madam, Dr. Devendra, and Dr. Pratyusha. Over to you, Dr. Rahul.
So, good evening, all. Are my slides visible?
Yes, sir. Yes.
So, good evening to all. I have tried to make it simple and easy for the postgraduates. I hope I'm able to justify this. So, I'm going to talk basically about the applications of OCT. I think OCT is the most commonly used investigation for retina, at least I would like to say. We all know it is used for the detection of the morphological changes of the retina, the retinal thickness, the retinal volume, the other features being the RNFL thickness and other various other parameters of the optic nerve head. The basic principle of OCT is based on the low coherence interferometry, and the Michelson's interferometer is used. So I'll directly go to what. So basically, light from an OCT system is broken into 2 arms: the sample arm, which is the item of the interest, and the reference arm, which is usually the mirror. The combination of the reflected light from the sample arm and the reference arm gives rise to the interference pattern, but only if light from both the arms has traveled the same optical distance. That is, the difference is less than the coherence length. So then only we can acquire this. The areas of the sample that reflect back a lot of light will create greater interference than that they don't. Any light outside the short coherence length will not interfere and will not be recorded. So the reflectivity profile is also called the A scan, and it contains information about the spatial dimensions and location of the structures within the item of interest. A cross-sectional tomograph, which is also known as the B scan, may be achieved by laterally combining the series of axial A scans. So this is what the principle of OCT is. Sorry. This is the what I would like to add also. When the mirror, when both the lights are taken from the mirror, they are in phase with each other. So they cannot be taken. So what happens is the phase difference has to be created. For this, the mirror is moved, one of the mirror is moved a distance so that the phase difference is there and the interference can be then intercepted by the detector. So this is the basic principle. Grossly, I've tried to tell you. So I'll take you back to the time domain OCT, which was the mid 90s when this came into play. This used to take sequential 1 pixel at a time, acquires around 400 A scans per second. The axial resolution is poor, more than 10 microns, and it has a low signal to noise ratio. On the other hand, what these days we have are the Fourier domain OCTs, which take simultaneous 1024 pixels, faster acquisition, approximately 26 to 40,000 scans per second, and a very good axial resolution of 3 to 5 microns, and a very high signal noise ratio. The newer ones being the swept source and the spectral domain OCTs. The spectral domain obtains time encoded information by sweeping a narrow broad bandwidth laser through the broad spectrum, and also it detects the backscattered intensity with a photodetector, not the spectrometer, whereas the SDOCT uses the charge coupled device camera for intercepting. Grossly, the resolution is the same for both, where the image depth is more for a swept source OCT than the SDOCT. I think this picture, all the PGs, all of us know, this is a normal OCT scan, what we see. And this is the gray scale, what we see. I think I will not go into the details of the retina per se. We all know we have 10 layers of retina. So in this, what we see is the vitreoretinal interface. This is the vitreous, this is the retina. We see a normal foveal contour, the intraretinal layers, the retinal pigment epithelium, and the layers, the choriocapillaries and the choroid beyond the RPE. This is the colored demonstration of the same thing. Again, the vitreoretinal interface, we can see the posterior highlight. These are normal layers, what we see in the retina, the retinal pigment epithelium, the foveal contour, and the choriocapillary layers. So the highly reflective membranes are bright in colors, that are the red and the yellow. And the low reflective membranes are the darker colors, that are the black and the blue. Sorry, I think the current went, so I must have lost internet connection. Am I audible?
Yes, Dr. Rahul, please go ahead.
Yes. Okay. So this is a normal OCT scan, what we see routinely. There are various scanning protocols we all know, the linear, circular, radial, and the parallel protocol. And the duration of the scan can be shortened by using the faster scans, which we do what we do. We acquire a lot of fast scans and average them to get the final interpretation. I'll just take you quickly through the various scanning patterns of two most commonly used machines, the OptiView, which has the line scan, which is a single horizontal scan of line high resolution, the cross scan, the radial scan, which is space 6 by 6, and the raster scan, what we see. The other scans being the 3D scan, the MM6, the EMM5, and the grid scans. The MM6 and the EMM5 are basically for the retinal thickness map, the inner and the outer retinal thickness map. And the grid scan are a 5 horizontal and 5 vertical grid pattern scan size being 6 by 2 millimeters. The other most commonly used machine, at least at our place, is the Zeiss Cirrus machine, and it has these various scans. I will not get into the details. The macular cube 200 by 200, the optic disc cube 5-line raster. We most commonly use the HDD1 line scan, which has got 21 high definition horizontal scan lines at the depth of 2 millimeters, and it can be adjustable in 3, 6, and 9 millimeter scans. And these are the various newer OCT machines available. The ultra high resolution OCT is the combined OCT SLO, the Doppler OCTs, the combined FFA with the NFAS OCT and the intraoperative OCT being the latest system. The axial resolution of the ultra high resolution is very high, approximately 3 microns, but the time acquisition is much more higher than the normal OCT, what we see. These OCTs are used in knowing about the photoreceptor layers when we are planning surgery for macular patients or any other patients, and also detection of milder forms of ERM and the vitreomacular traction. The high speed, ultra high resolution OCTs acquire imaging 100 times faster than the UHR OCT and 40 times faster than the standard OCTs what we have. The color Doppler OCT being a newer entry, and it basically they've done work on this in the larger vessels near the optic disc, and it has been mostly studied. So what my basic aim was that we should practically also understand how do we see an OCT, how do we interpret an OCT. So I've made 10 to 12 case-based scenarios where I'll be telling you how to interpret this OCTs. So this is a 45-year-old female with who's got diabetic retinopathy, a moderate NPDR, and this was the OCT picture what we saw. So in this, if we want to study this, the vitreoretinal interface is normal. This is the normal foveal contour we see on OCT. This appears normal. The intraretinal, the layers, they appear to be thickened. So this is some kind of a spongiform edema there. The retinal pigment epithelium, again, is normal. And we cannot see much beyond the RPE. So according to this, the OCT, clinically, we've seen a moderate NPDR. It is very important to correlate an OCT clinically. We cannot just comment on the OCT without knowing the clinical picture. So what we see most commonly is the moderate NPDR along with the spongiform edema. These are the other findings what we can see in these OCTs. Again, what you see is a normal vitreoretinal interface. The foveal contour is obliterated here. What we see is intraretinal cystic spaces. There is a large cyst at the subfoveal, and what we see is this. This is a neurosensory detachment. If you correlate clinically, we can also must have been seeing some hard exert. Sorry for not putting the picture here. This is other presentations what we can see in these diabetic patients. This is again a neurosensory detachment you can see, but at the vitreomacular interface, you can see this vitreomacular traction, which is physically causing this traction, leading to this neurosensory detachment. Most commonly seen picture, I think, in these diabetics are the cystoid macular edema. This must have been a hard exudate block. So these are the various pictures what we see in diabetic retinopathy patients with DME. So you have a cystoid macular edema, a neurosensory detachment, a spongiform edema, a vitreomacular traction, and a macular TRD. Again, this was a very these are again very common cases coming to our retina clinic. This was a 57-year-old male patient with hypertension. And what we see clinically is a superior temporal branch retinal vein occlusion in this patient. If you correlate clinically with the OCT, we went at with the OCT, you can see the segmental edema corresponding to the superior STBRVO. The vitreoretinal interface again is normal. The foveal contour obliterated. What we can see is intraretinal edema, and this is a neurosensory detachment. The RPE looks okay. And if you see these hard exudates, these are corresponding with this high inner plexiform layer, hard exudates, which is causing backshading also. I will not get into the detail of the treatment. We gave anti-VEGF, patient responded very well. Another picture very commonly seen, this is a patient with a central retinal vein occlusion. You can see clinically on your right side. We did an OCT, large intraretinal subfoveal cyst and lot of edema. The angiography was done. I'm not getting the angiography details of this. We gave anti-VEGFs, 2-3 anti-VEGFs. Patient responded very well. Again, these are very common presentations in our see. So this was actually a surprise. This was a paper published by the GNEC team in 2008, wherein first two pictures are very commonly seen in these retinal vein occlusion patients. But what they claimed in this paper that 15% of these patients just present with neurosensory detachments. So as I said, we have to correlate clinically all our patients before doing an OCT and only commenting on OCT. Very common picture seen in our clinics these days. This was a 32-year-old male patient, a smoker a type A personality, right eye presented with 15 days diminution of vision with a central scotoma. Went ahead, did an OCT, vitreoretinal interface is gone, foveal contour distorted. What we saw intraretinal layers appear normal. What we see is a large subretinal detachment, a large pocket of subretinal fluid with a small pigment epithelial detachment of the RPE. So this patient was a patient of CSR, very commonly acute CSR presentation of this patient. Well, role of OCT in acute CSR, clinically, yes, we can see these patients, but I usually prefer doing an OCT in these patients for a simple reason. These are mostly type A personalities and also help us in follow-up. So I prefer doing a OCT in these patients. This was again a patient who presented to us with diminution of vision for 6 months, best corrected visual acuity 6/24. Clinically, what we could see was a macular pucker, a epiretinal membrane. We went ahead with an OCT and we could see this membrane at the vitreoretinal interface. The intraretinal appear distorted. The foveal contour is totally distorted. The ellipsoid zone and the RP look intact in this OCT. So this is very important to look for when you are planning a surgery in these patients, because this helps us in prognosticating these patients pre-operatively. Another very common finding what we see in these patients, 57-year-old female patients. I think all of us can see this. This is a full thickness macular hole. Clinically, we went ahead, did an OCT in these patients. A full thickness macular hole. Surgery was done. Patient responded beautifully. 6 to 9 partial vision post-op. So what is important in these patients? What are the macular hole surgical predictors, and what is type 1 and type 2 macular hole closure? So these are the two most common predictors what we can predict on the basis of the OCT. One is the hole formation factor and the other is the macular hole index. So the hole formation factor is the height of the horns and divided by the length, the base. So C plus D by A. If it is less than 0.5, then the prognosis is poor. The whole thing is poor in these patients. On the other hand, the macular hole index, what we see, is B by A. B by A being the length of the horn along the base. And if it is more than 0.5, the prognosis is said to be very good in these patients. And these are the type 1 and type 2 closures for you. Type 1 closures where the horns also get opposed, but in a type 2 closure, the hole is closed, there is no subretinal fluid, but the horns are apart. So these are the type 1 and type 2 closures which can be picked up on OCT. So another case presented to us with distortion of vision. Clinically, what we could see was a fluid pocket there with a subretinal hemorrhage there. Went ahead, did an OCT, did an angiography. I have not put in the angiography. And what we see is the normal interface, foveal contour sort of maintained, intraretinal pockets of fluid, a subretinal pocket of fluid. And this is the area of RPECC thickening complex, suggesting of a CNVM, an idiopathic CNVM in this patient. So this was another case scenario. This is another case scenario. What we see, this was a central retinal artery occlusion. Though it is a clinical diagnosis, just to show you what we see is the thickening of the inner retinal layers, and this is how it appears on OCT. Optic nerve pit. Again, in this patient, you can see this pit and a fluid pocket connecting with a fluid. I had a video, it was not playing. I'm sorry. This is an old photograph what I had. So we could actually see a connection between the pit and the disc, and this is optic disc pit with maculopathy. Pre-retinal hemorrhage, again, just to show, usually we don't do OCTs in this patient because we cannot see the pathology beyond the hemorrhage because of backshotting of the hemorrhages. This is just for an interpretation of how an OCT can be seen in these patients. BKH, again, OCT can be used in seeing these patients, differentiating it from CSR. FFA ideally should be done, but you have these multiple pockets with undulations of RPE in a VKH patient, whereas in a CSR patients, you will not have these undulations. FFA, though, is a better diagnostic tool for differentiation. This is another patient of a BMT. What we see, a vitreomacular traction. For prognosticating, we have to tell the patient we did OCT in this patient. And this is how a VMT classically looks like. Another patient of albinism with foveal thinning and hypoplasia. Actually, we need not do an OCT in this patient, but this was done just to prognosticate and tell the patient how poor the prognosis is because of the OCT. So these were a few case scenarios, which I thought these are the common case scenarios which we see in our clinics day in, day out. Just my last slide, I just wanted to tell about OCT angiography, though it is not a part of today's program. So it is again a novel, a non-invasive technique, which takes care of the motion contrast imaging with high-speed imaging. So this has really helped us over the past 4-5 years since its inception in, I think, 2019-18. And we've been doing a lot, though it has not replaced angiography, but it's a very good diagnostic tool for angiography. Thank you. I think we can take questions. I can stop sharing. I think I finished fast.
Yes, Dr. Rahul, a very nice plethora of cases. I think it was very valuable for getting a good visual impression of how OCT looks in different clinical scenarios. Just to probably add on to that is that OCT is not, uh, as you quite correctly mentioned, it's not essential to form a diagnosis in many situations, but the OCT picture, which is oftentimes very typical of, gives a very good corroboration to the clinical impression that one may have when one sees the patient. So I think the value of OCT lies in the fact that it's very intuitive to understand. With a basic idea of the histopathology of the retina, it's very easy to correlate that. It gives you a very good, histopathological correlation. And of course, it's very easy for the patient to undergo because it's totally non-invasive. These are the reasons.
Follow-ups also. We can follow up the patient on OCTs.
Absolutely.
So that's another thing which.
Absolutely.
Can the PGs ask questions, or it's just us who have to discuss? Is there a chat
I think the
box
questions usually come from the postgraduates. In the meanwhile, you can add your inputs, madam.
Madam, it's like we just go on, keep on adding what is relevant and how to do that from our point of view. If you have any questions, then we'll take it in between. Otherwise, I now request Dr. Moona Bhinde, madam, to please give her view of thoughts.
Yeah, Dr. Rahul, a very nice crisp presentation on a subject that can go on forever.
Yes.
And I think you did cover a lot of things that are important for postgraduates to know. Probably a few points that I would, sorry, my camera seems to be focusing, defocusing, I don't know. Few points that postgraduates need to know. It is an optical phenomenon. So if you can't see, if your media is not clear enough, you're not going to get a good picture. So I think that's the first thing before you do an OCT is if you are not going to be seeing it, then neither will your OCT machine see it for you. And you did show a lot of color photographs. If there is a facility for black and white on the camera, on your OCT machine, definitely the images are better analyzed.
Better, yes.
Though patients always feel shortchanged when they see black and white. They say, why didn't you give me a color one? But I think if you want to analyze it, then the black and white is much better. And I would always recommend a cube scan to start with, because that scans the entire area, picks up areas which have a problem, and then you can go to your high density scans which scan a small area. Otherwise, you're likely to miss if you just use a radial scan, because you tend to use only vertical and horizontal. And that may not always involve the thing. And I think it's important to compare your OCT image with the color fundus image if you have a photograph or your fundus drawing. very often we see patients who go in for premium IO and they come with an OCT picture of a epiretinal membrane, and they have a good vision. Nobody's even seen the fundus. When you see the fundus, you realize it's just a thin, transparent membrane of no consequence at all. So I think before we make a diagnosis, it's important for us to know how significant that finding is and explain to the patient as well. And yeah, and you need a definite signal strength, say almost a 6 out of 10. If you don't see that 6 out of 10, it indicates that your scan is going to be inaccurate. So you may falsely interpret something, you may not see something well. That can happen if there's a dense posterior subcapsular cataract. So, and always choose the same landmark when you compare, so that you know whether the patient has responded or not. In diabetic macular edema, it may not matter too much, but if you're doing a vein occlusion where it's likely to be in the vertical meridian, then just taking a scan through the fovea may not show you anything at all, horizontal line scan. So I think these are just some points I thought on a practical basis, because nowadays OCT is such a part and parcel of our examination.
Thank you, madam. I think you have given a good input. So the one commonly asked question by the postgraduates, based on the OCT, how do we differentiate between CME and DME? That is the pseudophakic cystoid macular edema and the diabetic macular edema. It's very commonly asked question. So can you just elaborate few points on that, madam?
You want me to?
Yeah, please, ma'am. Yeah.
Okay, the first clue you would get is look at the red-free image, or the infrared image, or the color photograph on the left side. Never be shy to look at the image, because it will tell you so many things. Just looking at one scan may be a little difficult to tell you whether a patient has just a diabetic macular edema or pseudophakic CME, because even diabetic patients can develop pseudophakic CME. You have to look for other features like hyperreflective dots, and maybe not such a symmetrical pattern as you would see in a pseudophakic CME. You may see a little different distribution. You may even see microaneurysms, large microaneurysms. So I think those are probably points which would tell you whether it's DME or CME. But I think what we have to remember is every diabetic has a higher risk of developing pseudophakic CME, even if he doesn't have retinopathy to start with. So it could be either way.
Okay. I think the next I would request Dr. Devendra Venkatramani to please his point of view.
Yeah, just a few points is as Dr. Muna ma'am expressed, there are certain artifacts that one has to be a little cautious about, because ultimately it is, as we discussed, a light-based technology. So as ma'am mentioned, that in any time that there is something that is going to obstruct the light entry, although we must remember that it's based on a low intensity laser interferometry. So visible light, or newer machines which will be able to get you a signal or get you an image where you may not have been able to see something very well clinically, it is still going to be obstructed to some extent by some amounts of media opacity. So at the same time, there may be structures within the eye, whether they are in the form of vitreous hemorrhage or hard exudates or pigment, that may cause shadowing effects behind and may obscure the image behind. So one must try to understand those artifacts, recognize those artifacts for what they are, and not impute too much into a pathological basis for them apart from what they actually are being caused by. At the same time, as I said, because the technology is fairly advanced, you can see through a dense asteroid hyalosis, which may not be possible to visualize you may not be able to see the retina clinically, but you would be able to do an OCT and come to some conclusion as to the macular status. There are certain other niche indications when you are looking for unexplained vision loss, for example, in drug toxicities or patients who have very subtle early heredomacular degenerations, where the OCT may give you early signs of toxicity or and or changes of the outer retina, which would be useful in pointing to you to a retinal basis for the decreased vision of these patients. So, because of the tool's versatility and easy accessibility, I think nowadays more and more OCTs are being done in a general ophthalmic situation, as you know, as a percentage of volume. It is now becoming quite common to do an OCT as a pre-cataract surgery um, workup, so as to rule out the any structural macular abnormalities. At the same time, it's very important to understand that a normal OCT does not necessarily mean a normal macula, because structural changes in the OCT may be one thing, but there may be functional abnormalities which may not be picked up unless you are very careful with the OCT, and in some cases they may not be picked up by the OCT at all. So these are situations where one has to be a little cautious, and always refer the case to a retina colleague if you need any help.
Also, please correlate clinically. I think the big tagline is this: OCT should not be the only thing you should see. This has been happening very commonly, as Dr. He mentioned, pre-cataract package. It's become this thing. So I think more OCTs are being done than the retina specialist there. But please correlate clinically. Please see the fundus before commenting on the OCT.
Okay. So I have a question to all the panelists here. Actually, they had a question recently. Write a note on OCT angiography, mention its action, algorithm used, and clinical applications. So is there a simple way for them of how to remember these algorithms? Because it's a 5-mark question being asked to them basically on OCT angiography and algorithms. And I request all the experts here, is there any way where they can make a mnemonic or anything of that, or how they have to remember? Because when I see it again for the third time, I forget it for the fourth time. So any tips for the postgraduates, please? Starting from Mona, madam.
I thought Pratyusha will do it since she's purely academic set. Yeah, Pratyusha, why don't you
Yes,
take it?
Dr. Pratyusha, please.
For the OCTA algorithm?
Yes, that's the question asked. That's what I'm reading here. Write a note on OCT angiography. Mention its
In 5
mechanism of
marks.
action, algorithms used in
Okay.
clinical applications.
I think that is a question that is too high-fi for a postgraduate level. I think that is something that should be asked for a retina fellow or someone beyond that. But a simple method, I'm not sure.
I'll
So
just comment on this. I'm not sure if they actually meant the OMAG algorithms, the SADA, which I think
Optara,
is because those
Optara.
are the ones which are the actual algorithms.
Algorithms, right?
Whether that was what the person meant, which I think that is a machine specific thing.
And
Yeah.
that's more of an
So
engineering thing. It's
yeah,
Proprietary,
I
and they
do
would be
not,
proprietary.
and
So
they're all got their patents, which is why one says SADA and one has OMAC and all that. But I wonder if they actually meant you look at this plexus for seeing this, or whether that was what it was meant to be an algorithm. I don't know.
yeah,
Because
I would probably,
if you look at diabetic changes or RVO, you do the superficial and the deep capillary plexus, or if you're doing the choroidal neovascular membranes, you look at the avascular or the ORX lab. I wonder if that is what was meant.
But will they be asking a postgraduate these kind of?
Yeah, this was the question asked in the DNB paper. So few of them have already written OMAG, speckle variants, SADA, phase variants, Octara. I think the only way I would write to tell all my postgraduates is we need to by heart these terminologies.
Yeah.
There is, I think, no other way.
These are theoretical.
Understanding their mechanisms, these things, and try to correlate it. I think it's very, very difficult. So better is to look into the frequently asked questions in the last year exams. And if they are frequently asked, then just by hearted. I think the expert panel also agrees with me.
I think there will be a percentage of questions like this which you would not expect in a sense of routine. Neither do they have so much value at the postgraduate level, nor are they certain questions may be very esoteric and very niche. You may or may not be prepared for questions like this. Since it has been asked, it's probably worth going into a little depth and preparing yourself. But the chances that it is going to be asked again are obviously equally less. So I would just say that in the exam paper, if you do see something like this, it's probably, as Dr. Muna ma'am said, rather than trying to rack your brains or make up something, try to answer it in a simplified way as to what you understand about Okta. Even that may give a good enough impression that you are, at least to some extent conversant with the technology, and answer the same thing in a more basic manner would be my suggestion if you're faced with this situation.
So I don't think anyone expects you to explain SADA and things. Oh my God.
Correct.
Probably just
Mention
because,
those names.
yeah,
Mention
because
those
neither do we use it in clinical practice.
practice as well.
We use what machine we have. So I think
Dr. Pratyusha, your point of view on the OCT and its algorithms.
Most of the things have been already, said, but there are just a couple of things that I would like to tell the postgraduates. When you're interpreting an OCT, there are two aspects to it. One is you read it qualitatively. That is, you see what are the lesions that are present in the inner retina, in the outer retina, what is the foveal contour and the vitreoretinal interface and things like that. And the second aspect is the quantitative analysis. That is basically the thickness maps. So which of these you're going to choose in your patient depends upon the condition that you're dealing with. For example, if you're dealing with macular hole, there's no point in looking at a thickness map and trying to see where is the thickening and thinning. That's not going to give you any useful information. So there you want to look at you want to do a more of a qualitative analysis of the OCT scan in terms of what is the, what is the diameter of the macular hole, how are the edges of the macular hole, and things like that. And if you're dealing with a condition like diabetic macular edema or a vein occlusion, wherein you want to see whether the thickness is reducing, that's where you have to give more importance to the thickness maps. Okay, and in all these OCT systems that we have now, there is a feature called as eye tracking and auto rescan. The names vary from company to company, but that actually helps you to put the scan exactly at the same place on the retina when you scan the patient during the follow-up. For example, you're given an anti-VEGF or a steroid injection and you want to follow up this patient, you can actually use this feature to see if the thickness is reducing. Even subtle changes can be picked up. So what you're interpreting basically depends upon the clinical scenario. It depends upon the disease that you're trying to interpret. So this is one thing. And of course, as already mentioned, there are some artifacts that can happen on OCT images, especially in high myopes. You sometimes get, you get one OCT scan and then there is a reflection, something that looks like a reflection. That's called as a mirror artifact. And sometimes when the patient blinks, you will see one black line on an OCT image, especially when you look at the color image, you'll see that there's a black line when you're looking at the thickness map. So that indicates that the patient has actually blinked there. So you need to be aware of these various artifacts before you interpret an OCT image. And nowadays, we are not only looking at the entire thickness of the retina, starting all the way from the internal limiting membrane to the RP or the ISOS junction, depending on the device. We are also able to actually measure the thickness of individual retinal layers. This is just information that I'm giving you. Probably it might help you do some thesis on that topic. So individual retinal layers can actually be analyzed, and the thickness of each of these layers can also be got on the OCT machines. So if you take Spectralis, there is a feature called a segmentation. So once you do the segmentation, the machine automatically segments the different layers of the retina, the 10 layers, and then it gives out a map for each of the layer, the thickness of each of those layers. So, but then obviously before you look at the thickness map, you should always look at how the OCT has actually segmented those layers. You have to do a manual check whether those layers have been properly segmented, and then you can, you can then interpret the thickness. So why this is important is that there are certain diseases where specific layers of the retina get affected. Okay, for example, let's talk about the more common one, glaucoma. So now people are showing that ganglion cell layer thickness is reducing in patients with glaucoma. So if you check the total retinal thickness, you may not find big difference between a patient with glaucoma and a non-glaucomatous patient. But if you are actually looking at the ganglion cell layer and monitoring the changes in the ganglion cell layer, then probably you can see a thinning going on over there. So these are more of a research kind of things, but of course, basic things you need to understand is obviously the qualitative interpretation of the OCT, and then the quantitative, the thickness maps, and how do you understand whether the thickness is going down or whether thickness is increasing. Another thing that you have to remember when you're looking at these thickness maps is that you should make sure that the map is exactly centered on the same place as the previous scan. So it has to be fovea centered. Sometimes the machine puts the map, but then it is not centered on the fovea. So you will have to manually check where the center of the fovea is and whether this thickness map is actually on the foveal center. So that time there is an option to actually move the thickness grid to the foveal center and then interpret the thickness values. So these are some practical things that we see day to day. The rest of the things I think have been covered.
Srinivas, probably what postgraduates are asked also in the practical exam is to read an OCT, which the full map, not a single image. So they should be able to identify whatever is there, like identify the signal strength, identify that the scan is exactly overlaying the area of interest. And I think that is also important, and interpret the values, look at the scale that compares it with normative data, know what is green, what is red, what is yellow on the thickness scale. So I think that is also something people need to know. I'm not sure if we are allowed to do it, but I just picked out one of these normal maps from one of my presentations. If I'm allowed to share it,
Please go ahead, ma'am.
Srinivas.
Please do, ma'am.
Yeah, 1 minute. Can you see my screen?
Yes, yes.
Yeah. So basically, this is a cirrus image of a macular cube, which we would use to normally do the first scan for a patient. So what is important is to look for the signal strength. Here you see a signal strength of 8/10, indicating that it is excellent. And if you look below, you see macular cube 512/128. That means it's that many scans in the horizontal and vertical direction. You see that the scan is perfectly centered on the fovea. So you have a transparency of 50/50, which means you can see that exactly where the scan is centered on the red-free image. And if you look here, all the measurements are green, and that compares very well with the normative data. So this is actually a normal scan. And then you start looking at your horizontal and vertical scans. You can see all the layers of the retina well. There is no distortion of any foveal contour. Then you can look at the other ANFAS maps of the ILM-RP, the ILM, and the RT here. You see the central subfield thickness, the cube volume, and cube average thickness in machines like the Cirrus. It gives you the color, so you know this is a perfectly normal scan. So if you see a scan like this in a patient who wants to have a premium IOL, then probably macular-wise, this is a good candidate. So I just thought I'll share this screen for you.
Thank you. Thank you, Muna madam. That was really good tips and information. Just to, for the sake of completion, I think the another one topic which is also there is the intraoperative OCT. So along with the OCT, so in the intraoperative OCT, if they ask what are the different types, then you have handheld intraoperative OCT, you have microscope mounted intraoperative OCTs, and microscope integrated. So microscope integrated is one where we get the real-time visualization of the tissues, and definitely the concurrent tissue, that is the instrumentation interactions, that all can be done. So I don't think they are going to ask which machine is going to have that, but it's good to know that it's mounted on the Rescan 700 or even the Heidelberg, this thing. So the acquisition time is around 28,000 A scans per second. So it's slightly slower as compared to majority of the newer machines which have around 1 lakh A scans per second. But definitely you need to know, as it was described, you can have a line scan, the 5 line, the crosshair, the cube sections, and most of these can also be obtained with the intraoperative OCT. So this is just one point I want to mention so that we can have a completion of the topic. So I just want to ask the panelists here, because nowadays majority are fancied by the different newer OCT terminologies. Some may say that it is SAN-fill, DON-fill, ORDs, BRPs, and all those things. So, Dr. Pratyusha, since you are in a medical college, and so we have built this program so that we have the DNB teachers and the MS teachers as well. Because there is a thin line of difference. The exam pattern which is being done for the postgraduates in the MS is slightly different from what is done for the DNB students. So what is your suggestion whenever it comes to these fancy terminologies? Because I have seen in the DNB teachers or something, they ask what is downfill if the macular case, whole case comes. So to what extent the PG should be prepared, Dr. Pratyusha?
Sir, I think these fancy terms are okay to know, but then if they don't know the basic interpretation, if they're not familiar, these are all the ones that are going to give them a gold medal. But what they need to know is at least they should be able to decently read the OCT report. They should be able to tell these are the lesions that they can see, and this is what the map is showing, and things like that. That much is enough to crack the exam. They really don't need to break their head about these fancy terminologies, because if they know, it is fine. Otherwise, they're just wasting their time. There's so much else to study as a PG. It's not only OCT and macula and things like that. They have the entire anterior segment, the oculoplasty, neuro-ophthalmology. So I think they should not get bogged down with these things. These are just it's just a kind of an icing on the cake.
Okay,
Yeah,
so
I would wholeheartedly agree, and I'll also give you a little bit of a perspective on the FRCS pattern, where OCT is a very commonly kept OSCE, and surprisingly, many times it may form a part of the OSCE of the anterior segment viva, because as we discussed, many of the times the OCT is used to detect these pathologies which are relevant to an anterior segment surgeon, like pseudophakic CME, as we touched upon, and preoperative OCT, diabetic patients. So the pattern of the exam is basically focused towards more basic knowledge as to whether you are able to identify the pathology correlated with the clinical situation that is provided to you. Often, I mean, always there will be a clinical background to that picture. And are you able to sort of come to a conclusion and then give some ideas about your views on management? So, I mean, even for foreign examinations, these kind of exceptionally complicated latest terminologies, treatment algorithms, or image algorithms are really nowhere close to what is being asked. It's a very basic kind of knowledge to test your safety and competence at identifying these lesions.
Okay, Devin sir, as you said that you also have been one of the panel for the FRCS examination panel. So, because many of the postgraduates do appear for FRCS during their post-graduation itself, and many of them after taking that post-graduation. So, coming to the OCT biomarkers, so do they need to know about these OCT biomarkers? Because nowadays we use it in day in and day out, and some of them in the DNB institutions where they decide based on that. And so I just want to know how we should prepare for the post-graduation level itself, and then step it up to the FRCS or the FRC oft or the MRC oft.
So certainly, I mean, see, some OCT biomarkers which are obvious in the sense that they correlate well with pathology, they correlate well with the biological, let us say, plausibility of vision and treatment and response to treatment. These are easy to remember, and these one would naturally be easy. It would be easy for anybody to identify. For example, the extent of hard exudates or the presence of various morphological subtypes of the macular edema in a diabetic patient. These are very well correlated also clinically. From the FRCS examination point of view, these are probably again superfluous or a little too advanced, because the exam is more oriented to looking at whether you are a safe general ophthalmologist. You don't have to demonstrate great exceptional skills in diagnosing and treating retinal conditions, but you should be able to identify very clearly in your own head that this is this condition and I need to now refer this patient. And you should have an obvious idea as to how that condition is treated. You may not be responsible for the treatment, but you would know, you should know that patients with this kind of edema or this long-standing edema would not do as well. So this kind of prognostication, counseling of patient is definitely part of your purview as a general ophthalmologist, even before referral. So while terminology and technicality is not tested, your breadth of knowledge is very important. It's not so much the depth, it's the breadth of knowledge as a safe general ophthalmologist, which is definitely being scrutinized.
Thank you. I think received one question here is again, I think Muna madam already answered that the differences between the DME and the pseudophakic CME. She has told it. Just to add a few on that, I think madam has already said that you need to look on the hyperreflective foci. If they are there, then they are most likely to be a part of DME, not a CME. And also subretinal fluid, if you think, yes, the pseudophakic CME has more amount of subretinal fluid as compared to the DME. DME can have subretinal fluid along with the intraretinal fluid, or it can have only intraretinal fluid as well. But if you look into the location of the cysts, I think that is also equally important because most of these DMEs we see more in the ONL or the Henle's layer, whereas the pseudophakic CME is where it starts with the INL. So that's the one, the location of the cyst initially. Of course, later on, it can have both in the ONL as well as in the INL, but definitely it is better to know where it starts with initially. And the hyperreflective lines of the outer retina are usually preserved in case of the pseudophakic CME, whereas in case of DME, it is usually disrupted. I think the other of the things have already been told by Muna madam pretty well on these aspects. So I think
Also, please look at NPDR if there are diabetic other changes also. So that is also important in this differentiating between a DME and a pseudophakic CME. Look at the other eye also for diabetic changes.
One other thing I just want to add.
Yes, Dr.
May not be as a part of the examination purpose, but please don't treat OCTs. Treat the patient.
Yes.
So always look at an OCT, see whether the patient is having edema or whatever is the lesion that you're treating, but also take just 2 seconds to ask the patient whether the previous injection has really helped the patient improve his vision or not. So just don't keep on injecting just because you're seeing edema on the OCT. So treat the patient as a whole and not the OCT.
Just one question, Dr. Pratyusha, because in the Viva, most of these OCTs will be asked in the Viva.
Yeah.
So it will be given as a chart reading.
Right.
So when given as a chart reading, they usually basically just give the OCT with the findings. Right? Am I right? Please correct me if I'm wrong. So when given like that, then should we ask the examiner that what is the history and what are all those things? Or because sometimes too much, questioning the examiner also might raise the eyebrows. So to what level? So just can you help these kids on whether just to read, because they are not given the patient and they're just given the charts.
Right. So, I mean, if I would be the examiner, I would be very happy if the candidate would ask me what is the clinical history and what is the retinopathy status, what is the color fundus photograph. At least these are the 3 basic things. You need to know what is the clinical history. You need to know what is the color fundus photograph, or if you have done a retinal examination, what is it showing? These are the 2 basic things. I think that much. Ideally, when you give these, any kind of reports for interpretation, it should be along with a small clinical description, because time and again everybody is telling that you should not interpret an investigation without the background of clinical examination and history. But at the same time, in the examination, if you don't give these 2 and you don't want the PG to even ask you that question, I don't think we are fair in actually evaluating these these students. But all said and done, yes, it can be a double-edged sword. If you keep on asking questions, the examiner might think who is actually giving the exam here. So I think, when you're given just an OCT without any clinical history or fundus this thing, instead of questioning, you can say, you can probably answer it like, yes, this is an OCT which is showing this. This could be, if they have given, say it's a diabetic patient, then you can say that, supposing they ask what is the treatment, then you can say, okay, if this patient is having a non-proliferative diabetic retinopathy with macular edema, I would treat with intravitreal injections. Or if the patient is having proliferative diabetic retinopathy with diabetic macular edema, you can yourself, volunteer to create 2-3 scenarios and answer those questions. That is one way of doing it without hurting the examiner as well. But I think there is no harm in asking, what was the retinopathy status or what is the clinical history. I think there is no harm in that.
But you can also provide a structural interpretation.
Yes, rather than a
Yeah.
diagnosis.
Yeah, don't give a diagnosis. You say
Yeah.
the foveal contour is altered,
Yeah.
or the fovea is elevated, fovea is everted, you
As
have cysts in
mentioned,
the outer nuclear or
descriptive
outer.
appearance of the
Yeah. And then putting it all together, if the patient is diabetic, it's likely to be DME.
Yeah.
So something like that is probably what, if I was examiner, I would look for.
Yeah.
Definitely not Donfil and things like that. Yeah.
But we being a center for DNB, usually a fundus photo is given from our side along with the OCT if we plan to give an OCT.
Yeah.
So to keep life easy for the
Yeah.
student who's appearing. It is not ki bhaiya bataye kya hai. It is very difficult to say. Yeah, so usually it is done.
You know, I may just tend to disagree. It's very easy to say. The problem is that it's very easy to interpret an OCT and get to a wrong conclusion if you're not careful. Which is why probably it is not advisable to give WhatsApp opinions on OCTs. But the problem is that in an exam situation, you could, as very correctly said, you could give your structural pathology, and then you could say that these could be the differential diagnosis. I would like to know this about the status of the patient, and then beyond that the discussion would go.
When I went as MS examiner, they refused to let me ask retina questions.
Yeah. Excellent. I mean, that's an FRCS.
Yeah, that's what they did. So I had to ask orbit and neuro.
Yes. Generally, they even in the FRCS
Yeah.
examination, they won't permit you to be an
Yeah,
examiner.
they
for the
didn't
station
allow
that
me
you are
to
the
ask the retina questions.
Very
Wow.
nice.
So I think we have last 3 minutes, 1 minute to each panelist. Your closing remarks. We'll start with Dr. Rahul.
So I think as we've had a lot of discussion, one thing which I skipped actually purposefully was EDI, which is again a feature of OCT, wherein a lot of pachychoroid is been going on. But I thought it is, I tried to make it for the PG, so that is why I didn't add it. So that was one thing, the extended depth of focus imaging for the choroid, what we see on pachychoroid spectrum, what we've been talking about of late. Rest, I think Muna madam has shown the. I also feel it's more of a normative thing what we should know. Where once you get into the fellowship programs and other things, I think that is the time when you see more and learn more of these terminologies as mentioned. So keep life simple as a postgraduate. This is what my take is.
Dr. Pratyusha.
Yeah, I think more what I agree what Dr. Rahul had to say. Keep your life simple, stick to the basics, because more often, when you try to learn too many things, you tend to forget the basics. So just stick on to the basics, learn something about everything, every topic you should know. So try to get some knowledge about every topic that is there in the entire ophthalmology textbook, rather than trying to read in depth about one particular topic, because that is a very dangerous thing to do before an exam. So I think, yeah, all the best.
Dr. Devendra.
I'll just say that if you're asked OCT, consider yourself lucky because you've not been asked ERG or VEP or EOG. So OCT is something you will hit out of the park. So I hope everybody's asked OCT in the exam.
So Dr. Pratyusha, just one more question. So if you ask OCT, I'm not sure whether you're not given the ERG or the VEP responses also, because in the chart reading, I think it always depends upon the level the kids goes on answering. So
Yes,
if they
yes.
keep answering more and more, I think then the step will come where they will reach to ERG and VEP
Yes.
also.
That's true. I mean, there is a knack of answering these exams. You can actually drag the examiner to what you know rather than to the domains that you don't know.
So one more thing, as Madam said, she was not allowed to ask even retina questions. I think leave OCT. So I feel if you are being asked an OCT, that means you're through the exam. They're trying to just assess you for a gold medal.
No, maybe one point I would say everyone
Yes.
should know is learn the layers of the retina by heart. Forget SADA algorithms. You should
Yes.
be able to describe them in order from inside to out, outside to in. And that is absolute basic. Correlate them with the histology. And if you know that by heart, then describing it is not going to be difficult. So I think that is probably the first thing, identifying layers on a high quality scan. What is OPL, what is IPL, what is INL? That is most important, that what people are likely to ask. I'd say that's the most important.
Great. So thank you so much. We are 9:01, right on dot on time. And I think the postgraduates will really enjoy this session if they go through it completely till the end. A lot of learning tips provided by Moona Madam, Dr. Devendra, Dr. Pratyusha, and a wonderful talk by Dr. Rahul Mayer. So on behalf of ARC, I'm really thankful to all of you for giving such a meaningful advices and the take-home messages. I would also like to thank Tushar and also Sunil from the support admin. And on behalf of entire AIOS, we are thankful to each and every one of you for attending this webinar. And this will be posted in the ARC YouTube channel. You can just view it in a few days. I think Mr. Sunil will be posting it, and then you can definitely go through it once again, as and when required. Also for your revisions of your exams, definitely you can go through it. So with this, I would like to conclude. Thank you very much, all of you, once again, from on the chairman's desk. On behalf of the chairman, I would once again like to thank you all. Bye bye. Good night.
Thank you so much.
Bye-bye.
Thank
Thank
you.
you.
Bye.
Bye.